Good evening. Mr. Saji, you there?
Yes, ma'am.
Good evening.
Good evening, ma'am.
Uh,
Yogesh is there. I've informed Vasan, sir. Madam also have
okay.
prepared the plan. I'm just waiting for our response. She's traveling. Also.
Okay. I think Dr. Sunil has some time constraints. He needs to travel also, so he will go first. So we'll get started as early as possible.
पच्चीस दिन शाम तक पूछेगा
Hello.
Good evening, Dr. Yogesh.
Yeah, good evening, good evening. I think my video is not working.
Not sure.
Yeah,
It
no,
was working.
working. But I am not.
I can't see your video.
Yeah, here I am not seeing my video here. Just yeah, my
Yes.
photograph is there.
Yes.
Yeah, but I think
Maybe you've blocked it. You can just check on the
no.
icon down.
Something is wrong here. Video setting. Grade now. Let me log in again.
Yes, doctor.
Yeah.
I am just trying to coordinate with the speakers. They're indicating some difficulty in logging in. Dr. Anand, I'm not sure. Good evening, all. I'm having some difficulties in coordinating with the speakers. Dr. Sunil Bhat is in the airport and he's finding some difficulty in connectivity. I'll just sort this and be back with you. Dr. Anand, are you in?
Yeah, good evening, Dr. Vanita. This is Anand here. Nice to
Good
be here.
evening, Doctor. Good evening, Doctor. Welcome. I
Thank you. Thank
have some change of plans as I coordinated with you earlier. Dr. Sunil Bhat is right now with me. He's saying he's in the airport and is unable to
Okay.
log in from the airport. So I will just sort this and we'll have the formalities from the IAP. And would it be possible for you to start as we had planned before?
Yeah, that's fine. Let me just pull up my presentation and then we can
Yes,
start.
doctor. You can just keep that ready while I start with my introduction, and IAP dignitaries will be having a few forward before we get started.
Sure.
Is that possible, doctor?
And if I find some technical challenges with sharing, I think I shared it with you. So if you can share from your
Yes,
side,
I
then
can
we
do
can.
that. I can
Then
do the
your
backup,
coordinator
doctor.
can give me access also.
Okay, doctor.
Sure. Thank you.
Welcome, doctor. It's 4 o'clock. Thank you for the audience for patiently waiting. Good evening. A warm welcome to you all. Uh, uh, Before proceeding, a brief introduction, and then we will get started. Both the speakers have some time constraints so that we happen to comply with the timings as planned. I am Dr. Vanita. I'm the IAP, AMH, and Bahrain chapter president, and I'll be your moderator today. Uh, as always, we do our monthly webinars in pediatric subspecialties, and the activity has been championed by IIP Liaison Dr. Ranjan Pejawar. Today's theme is pediatric hematology, and the IAP dignitaries are held up in the IIP presidential elections. But Dr. Yogesh Parekh, I saw, would be having a few words of introduction before we proceed with the actual activity. Dr. Yogesh,
Yeah,
are you available for
thank
a few
you,
words?
Dr. Vanitha Madam, for this wonderful initiative with the AMH IP webinar. And today we are having this is the 11th episodes of this our collaboration, and very wonderful theme of the pediatric hematology, and both the experts, Dr. Anand Prakash and Dr. Sunil Bhat, will deliver the best for the pediatric current concept on the cardiology and bone marrow transplant in the pediatric disease. So, with the our liaison international liaison committee, Dr. Ranjan Pejawar, and our president, Dr. Vasant Khalatkar, Dr. Neelam Mohan Madam, Dr. Basavaraj, and Dr. Mohammed Salman, and all of you are having this learning today. So let us start the learning with the help of our American Mission Hospital, and happy learning. All the participants enjoy the today's program, and thank you very much, Dr. Vanitha. Over to you, please.
Thank you, Dr. Yogesh. Uh, with a brief introduction of the theme and the experts, I will hand the floor to Dr. Anand. There is some difficulty with the logging in of another speaker, Dr. Sunil Bhatt, and I will sort it if by the time Dr. Anand's first talk is delivered. Pediatric hematology. We are all uh, always intrigued by it, by the complexities as well as the challenging nature of this dynamic field. This is an evolving field, and early recognition and timely intervention is always a compulsion on the pediatric practitioners. And that's how this theme happened to be today's topic. We always design our webinars in such a way that it's a pediatric practice changing or update informing kind of situation. And pediatric hematology, we were wondering what can be delivered from our experts. And IAP has always positioned our experts to deliver such concepts to pediatric practitioners. We design it in such a way that we have a local expert delivering a regional guidelines and updates for the audience, but then today we devised it in a different fashion. There'll be two speakers from IAP who will be delivering concepts which should be very useful for pediatric practitioners. Dr. Anand Prakash would be delivering a topic on HLH, hemophagocytic lymphocytosis. The follow-up topic would be bone marrow transplantation from Dr. Sunil Bhat, if we happen to get him to log in. Dr. Anand Prakash is a hemato-oncologist, pediatric hemato-oncologist from St. John's Medical College, Bangalore.
Dr. Vanita, sorry to interrupt you. I have logged in. Sorry,
Okay.
it took me a little time to log in. So if Anand is okay, can I do the first? If it's okay, if not, then I will hold on for some time.
Okay, doctor,
Yeah,
I'll just have
I'm
you
okay
both
with
decide.
whatever works. No worries. No worries.
Sorry for that.
Okay.
Not at all. Not
Okay. So we have two eminent hemato-oncologists from pediatric hemato-oncologists. So back-to-back introductions. I was trying to introduce Dr. Anand. Now, Dr. Sunil Bhat would go first, and we will have the theme discussion being chaired by Dr. Anand, because I understand that Dr. Sunil Bhat is constrained by time. So let me introduce Dr. Sunil Bhat, who would be going first. He would be talking about bone marrow transplants in pediatrics. Uh, Dr. Sunil Bhat is a pediatric hemato-oncologist, as I said, from Bangalore, Narayana Group. And I would have him talk the concept and put their CVs on the group for the use of the audience. So I would have Dr. Sunil Bhat go, and we will get started. Dr. Sunil Bhat, the platform is yours. Please get started. Thank you, Dr. Anand, for
Well, thank
the
you.
dilly-dallying of the
I
lead
know.
concept. We will have Dr. Sunil first, and thank you for understanding for rescheduling the concept. Please go ahead, Dr. Sunil.
So good evening, everyone. And first of all, thank you very much, Dr. Vanita and IIP Bahrain for having this session. And sincere apologies to Dr. Anand as well for this confusion in login. So, as has been introduced, I will be discussing with you in the next 20-25 minutes stem cell transplantation in pediatric diseases. So before we do that, I just wanted to run through a case with you, which was a case of a 16-month-old baby, not gaining weight, multiple swellings all over the body with abdominal distension for 6 months duration when he presented to us. Secondary consanguineous marriage and the only living child in the family, because older two children who were born to this family had a disseminated BCG infection and died of BCG, infection, and died at 6 months of age. And because of this history, fortunately, this child was not vaccinated. He was well till 9 months of age, but then started developing regular pneumonias, was started anti-tubercular drugs because of their family history, no response, and started developing these multiple swellings all over the body and abdominal distension, failure to thrive in spite of having a very, very good appetite. This is the child, consent for the picture is taken. He was pale, he had generalized lymphadenopathy, and a very typical rash all over his body, and organomegaly, which was liver and big spleen. The routine evaluation showed he was quite pale, he had high white leukocyte count. Routine evaluations which were done for tuberculosis, for torch infections, electrophoresis, they were all negative. In absence of a diagnosis, we did a liver and lymph node biopsy, which revealed significant lymphocyte infiltration. And those lymphocytes were positive for what we call a CD5 and CD3, that's the T lymphocyte, but didn't really give a diagnosis at all. Now, with the history of, two sibling deaths, which died of infection, which is usually not pathogenic in immune competent host, that is BCG. So we suspected immunodeficiency. CGD and chronic lymphocyte adhesion defects are the two typical ones which present similarly, but they were negative. Immunoglobulin levels are normal. And we said a T and B subset functions to NIH Mumbai. Now, this is many, many years ago, almost 10 years ago. And that point of time, we didn't have access to these subsets readily. And what NIH Mumbai told us that the T and B subsets numbers were normal. But the problem with this child was that the T lymphocytes were not proliferating the stimulus, and stimulus was for T cell antigenic stimulus. And because of that, a functional defect of T cell, a diagnosis of T cell function defect was made. And this was confirmed at two different settings because the sample had to travel to Mumbai just to make sure that it's not a problem of sampling, and it was confirmed on two different occasions. Now, this is, as I said, long time ago, and that time getting T and B subset numbers also was a little difficult, and we didn't have access to mutation analysis at that point of time. So we knew that this child has T cell functional defect. The only cure for this condition would be a bone marrow transplant, and this family, we counseled. There were no matched sibling donors because, as I said, older two siblings had already died with a similar illness. There were no unrelated donors, and we used one of the half-matched parent as a donor. As we didn't have a genetic diagnosis, and as we know, most of these immunodeficiencies either are X-linked or autosomal recessive. So at the most, it was also recessive. Both the parents would be carriers. The X-linked mother would be a carrier, and hence to be on the safer side, we choose father as a donor because if it's autosomal recessive, the father will be just a carrier, and we can use them as a donors for transplantation. So then the child is at a transplant. We're using father stem cells. This is the same kid now, almost a month out in the transplant. He's changed completely. He's put on weight. The skin rash has resolved. Organomegaly has resolved. And if you see his what we call as engraftment has happened, and the donor cells are 100% at 1 month post-transplant. This child is almost 10, 11 years old post-transplant now, cured of his disease and going to school and is doing very, very well. So this is just to kind of highlight the role of stem cell transplant similar disease. While we were treating this family, this child, actually the mother was 16 weeks pregnant. As we didn't have a genetic diagnosis, we would offer a prenatal genetic diagnosis for the family, and family were counseled with the potential of another child having the same disease. They continued pregnancy, and the fourth child also had similar disease. We checked the T cell function on the sample of the newborn baby, and that also had T cell.
It seems like we lost connection with Dr. Sunil Bhat. Doctor, we lost you briefly. Doctor, you're muted. Dr. Sunil Bhat, you're muted. Can you unmute yourself?
Hello?
Yes,
Hello?
doctor.
You
We
can hear me?
lost you after you finished presenting the case, doctor.
Okay, now you can hear me now?
Yes, doctor. Yes.
Okay.
We don't have the presentation on.
Yes, I'm putting it up again.
Yes, doctor.
Right. So,
We are in.
as we were looking at family, the fourth baby also was diagnosed the same problem. The fourth baby also had a transplant using father stem cells, also cured of this condition. So this was just a case to highlight, these conditions can be devastating. They can, not only affect the children, but also the families and extended families and families, looking after these children for years together. and but fortunately now they have two healthy children post stem cell transplant. And this is retrospect actually. So we take the blood sample of the index child, and one of the labs in the Bangalore then offered to do genetic sequencing on that, and interferon gamma 2 receptor mutation was identified in this index child, which was confirmed being carriers in the both the parents as well as the fourth child as well. And this is a novel mutation which has been reported in one of the publications by our group. So that was just to highlight and put some context to what we're going to discuss today. But going to a little bit of the history, the stem cell transplantation is not something which is new. So 1958 was the first transplant which was done on a child with ALL, acute lymphoblastic leukemia, and that child underwent transplant using one of the siblings as a source of stem cells by this gentleman here called Esau Donald Thomas, for that which required, was received Nobel Prize in 1990. So a lot of contribution actually pediatrics has made in the transplant field, and the first patient who ever got transplant was a child with ALL. But in the next few cases, the transplants actually was not successful. These patients used to develop profuse diarrhea, very bad skin rash, and liver dysfunction. And for the want of a better name, it was called as second disease. And the people didn't understand, physicians didn't understand what was the reason. This was happening all in Seattle. They stopped the transplant program, and they went back into humans in dogs first, and did some dog experiments and identified something called as canine or dog leukocyte antigen system. And they came back in humans and identified something called as HLA or human leukocyte antigen system, and that kind of made the transplant programs to be viable again. Now, the first patient who had transplant, which I showed you by Esau Donald Thomas, had a transplant using his identical twin as a source of stem cells. And as a result, it by chance, the HLA was matching. But the patients who had transplants after that, HLA was not known, so HLA was not done, and the HLA did not match. And this patient developed what's called as graft versus host disease. And hence, after the introduction of the HLA and after it became known, the transplant activity started again. And the next 10 years, it was only the malignancies which were transplanted. But then, in 1968, first non-malignant transplant was done, and it was done on a patient with X-linked immunodeficiency by the gentleman here, who is called Robert Good and considered as father of modern immunology. And this kind of paved the way for non-malignant transplants after that. And this was again a child who had X-linked immunodeficiency, and these kind of transplants started after that time. Now, 1989 saw the first cord blood transplant, which was done by this lady here called El Gluckman, and this was done on a child again, a pediatric patient who had Fanconi anemia. This child was a U.S. citizen, and at that point of time, in U.S., FDA had not approved cord blood transplants, and hence the child was flown down to Paris, had a transplant using cord blood transplant, and then was cured of his Fanconi anemia. And that child now is actually in his early 50s and is cured of his Fanconi anemia, and that kind of paved the way for cord blood transplant. So that was some history and the introduction of how the pediatric has played a role in the history and evolution of cord blood transplants. I mentioned about HLA typing. So one of the differences between cord blood transplant and the stem cell and the solid transplant, there's liver or kidney, is that in a solid organ transplant, liver, kidney, pancreas, heart, you just need a HLA compatibility. You need a blood group compatibility between the patient and the donor. But in stem cell transplants, you require a HLA compatibility between the patient and the donor. And we know that HLA we get half from the mother and half from the father. It comes as a haplotypes from each parent. And the chances that our siblings are a match are the highest, because we inherit a haplotype from our parents. And this example of HLA the patient here 11. If you see, the brother is A111 and second brother is A1. So this brother is what we call a 6x6 match, and the second brother is actually not a match. So there's a 25 to 30% chances of finding a sibling donor match in the family. Now, we discussed about a case, we discussed about the history of transplantation, we discussed about HLA typing, and now we're going to discuss about the different types of transplants which are done in pediatric practice. So one is something called as autologous transplant. That means you're taking the stem cells of the patient and giving it back to the patient. That's called as autologous transplant. Now, allogenic transplant is meaning taking stem cells from a healthy donor, and that healthy donor can be matched sibling, which was the traditional way of giving stem cells from a sibling who's a match. But then, as I said, 25% of the times only will find a sibling who's a match. We can have unrelated donors who can be donors, and there's a chance 1 in 20,000 to 1 in a million that someone else in the same in the world can have the same HLA typing as the patient has got, and those can be as unrelated donors, and that we do from our unrelated donor registries. The chances of finding unrelated donor registry full match donor in our country for our patients about 10 to 15%. So that is another 60 odd percent patients without a donor who wouldn't have a family or an unrelated donor to donate for them. For them, we can use a haplotransplantation or a half match transplant. As I said, parents are always half match, and that's kind of open an option for practically every patient to undergo a transplantation. That can be also a source of stem cells. That's called as haplotransplantation. And cord blood can also be the source of stem cells, and that I mentioned in the history of evolution of transplants. Very rarely you can have identical twin as a donor, and that's called a syngenic transplant. And that's also, as I said, the first transplant in the history was actually a syngenic transplant from identical sibling. Now, what are the ways we can collect the stem cells? The stem cells which are used for transplantation in the stem cell transplant of bone marrow transplantation are collected either from the bone marrow, they can be collected from the peripheral blood, or they can from the cord blood. Now, we'll discuss a minute about each one of them. Bone marrow is a traditional source of collecting stem cells. The donors are taken to operation theaters, is done under general anesthesia. It takes 1 to 2 hours. If you see the two operators here, they're extracting the bone marrow from the iliac crest of the donor, and this is used for transplant purposes. Now, you have to remember that we can take a maximum of 50 to 20 ml of marrow from the donor, and we need at least 5 to 10 ml per kg of marrow for the patient. And hence sometimes if this donor is very, very small, we may not get enough stem cells at one go for the transplant purposes, and that's one of the limitations of using bone.
We lost them briefly again. My apologies for the difficulties and Dr. Sunil Bhatt's connectivity. We'll wait for a while. I think he's trying to log in again. Dr. Sunil, you may have been muted again. Can you? You're muted again, doctor.
Hello.
Yes, doctor.
Hello.
Doctor, you're in. You can restart.
I'm so sorry.
Yes, doctor. Please go ahead.
Yeah. Can't see the
Just when
slides.
it
Can you
was
see the
getting very
slides?
interesting, we got interrupted.
I know.
So I think you can proceed. It's in.
Just 1 second. Yeah. Um,
You can share, doctor.
yeah, I'm doing that now. I think
Yeah. Thank you, doc.
yeah. So this is how a peripheral stem cell collection is done. So it takes 3 to 4 hours. It's outpatient, and the comes to this into this machine. It spins the blood, takes the stem cells out, and blood goes back in. It's outpatient procedure. Advantage is that you don't have the discrepancy problem between the patient and the donor. You get a lot of stem cells here, but it does have a disadvantage of leading to more what we call as graft versus host disease. This is just a donor, donating his stem cells. The cells are the blood is taken from the femoral excess, goes in the machine, and then it spins the blood and collects the stem cells and goes back into the patient. As I said, cord blood can also be used as a source of stem cells. We know it's a dustbin product, and when the babies are born, the cord blood can be stored in the cord, can be taken and stored in cord blood banks, and can be used for transplant purposes. This is how the blood arrives at the transplant unit. It comes in liquid nitrogen or nitrogen tanks. This pouch of blood is taken out and then can be used for transplantation purposes. As there are two beautiful cord. One is that it is very rich in stem cells. The concentration of stem cells in the cord blood is very high. And it also comes from the newborn babies, which are immunologically naive. So hence, they do not have, kind of capacity to.
I guess we'll have to bear with this interruptions because he's logging in from the airport. We will
I
follow it up with a discussion to make up for the interruptions. We understand the interruptions, doctor. You can go ahead.
I know. So sorry about. I didn't expect this to happen. I thought it's um, going to be okay. Are you able to see me?
Yes, doctor. You'll have to just go to the
Yeah.
presentation mode if
So
it's possible.
that's the you can see the presentation because I can see it itself.
I can see the presentation, but not in the
Yeah.
presentation mode. It should be okay. We can. Yes, doctor.
Okay, so now what is the journey of the patient like during the transplant? So before we start to admit the patient, we will make sure that the donor is well, the patient is well, and they don't carry any comorbidities which can interfere or compromise the outcomes. Once that is done, patients admitted to the transplant unit and they undergo what's called a conditioning. Conditioning is is cocktail of medication given for a few days. It destroys the bone marrow of the patient. After that, the cells from the donor is given, whosoever the donor is, which we have discussed earlier on, and whatever be the source of stem cells, whether it's peripheral blood, bone marrow, or the cord blood, and this is given to the patient. Happens that everything kind of drops. The hemoglobin, platelet, white cells, everything drops. It becomes absolutely almost zero white cells for 2 to 3 weeks. And after 2 to 3 weeks, you see that the engraftment starts happening. The bone marrow starts working again. You see white cells coming up, followed by platelets, followed by hemoglobin, and when they come to the normal level, we discharge the patients from the hospital. Now, as we can imagine, this is the most important time point in the journey of the patient when the patient is completely plastic. They are a very high risk of infections. They develop mucositis. Some of them require total parenteral nutrition. We will have to deal with fever, infections, febrile neutropenia. But when the count starts going up, things start getting better. The patients can go on enteral nutrition. The fever starts settling down, and we discharge the patients from the hospital. Now, this is a cartoon exactly showing the same thing. So we have given conditioning, a period of neutropenia and period of bone aplasia, and engraftment happens. The story does not stop here. We need to follow these patients for months together for two important things. One is graft versus host disease. That cells of the donor can attack the patient's body, and that's called as graft versus host disease. It can happen in the few months post-transplant. It can sometimes happen in long term also, which is called as chronic graft versus host disease. We also look at something called as rejection, because sometimes the cells of the donor may not be accepted by the patient and the cells may be rejected, and that's called as rejection. Now, these are two important complications kind of thing which we have to follow up in the next few months to a year. But mostly what happens by 1 year, these patients are off immunosuppression, they are off all other medications, and they start schooling, they start vaccination, and they have to be revaccinated again, they start schooling again. So one of the differences between a solid organ transplant again and the bone marrow transplant is this, that solid organ transplant patients will be on lifelong immunosuppression, but stem cell transplant patients require immunosuppression for a few months to up to a year. Most of the times after 1 year, immunosuppression is stopped and they are like any other child in the community. Now, what are the diseases which we transplant? I told you about autologous transplantation, where the patient's own stem cells are taken and given back to the patient. Now, this is done in conditions which are actually malignancies outside the bone marrow, like Hodgkin's, non-Hodgkin's lymphoma, for example, neuroblastoma, some kind of brain tumors, where the malignancy is out of the bone marrow. What we do here is that we give them very high dose of chemotherapy and then give the cells which have been collected from them back to them. This helps their bone marrow to recover. Because the bone marrow is healthy, we do not require any other donor. We don't require, a healthy donor. Patient's own stem cells can be used to help them to overcome the effect of the chemotherapy. This is used for malignancies where the disease requires very high dose of chemotherapy. On the other hand, allogenic transplant, which means taking stem cells from a healthy donor, has got more varied indications. It's used for malignancies, especially leukemias, ALLs, and AMLs, sometimes with lymphomas where the bone marrow is involved, myelodysplasia. It's also used in a lot of non-malignant indications, which are very, very important for pediatric practice, like immunodeficiency syndromes. We discussed about it in the case, hemoglobinopathies like sickle cell and thalassemia, bone marrow failure syndromes, storage disorders, acquired condition like aplastic anemia. These are like, this is not an extensive list, but there's a flavor of the illnesses which are quite significant, quite life-threatening, and bone marrow transplant is probably one of the only treatment options for some of these conditions. Now, we'll quickly go through in the next 2-3 minutes in some of the conditions. Pediatric indications are slightly different from adults, and this is one of the group of conditions, which is the immunodeficiency, for example. In India, we are the immunodeficiency capital of the world. There's estimation that about 100,000 to 150,000 children in India are born with some kind of immunodeficiencies. There are various genes which can lead to severe common immunodeficiency, but then transplant is the only curative option for these conditions and is curative for these children. Infantile osteopetrosis, not very common a condition as immunodeficiencies, but we see this in consanguineous families, especially in southern part of India. And in this condition also, transplant is the only curative option except for one mutation, but all other mutations we can use transplant as a curative option. Now, talk about storage disorders. When we talk about storage disorders, we talk about enzyme replacement therapy, that being the treatment of choice. But ERT, or enzyme replacement therapy, has two problems. One is that it's too expensive and not available for all the conditions. And to manage that for lifelong, it's very, very difficult. Second, enzymes do not cross the blood-brain barriers, and hence your neurological deterioration can still continue even on ERT. But transplant can usually, stem cell transplant can be of curative, can help some of these patients, especially patients with MPS 1, 2, 6, and 7, where the new reticuloendothelial system, which has come with the transplant, makes this enzyme which is deficient and helps them, in the phenotype. And what's very important is the transplant should be done early in the life, especially if possible in the less than 2 years of age to have the maximum benefit. Same thing about lifestyle storage disorders like Gaucher type 1 and 2, Niemann-Pick BNC has got some doubtful role, leukocytosis, alpha mannosidosis. These are the conditions where again bone marrow transplant is helpful, but we have to remember that it has no role if For example, Gaucher type 2 or the neuronal form. Niemann-Pick type A, which is the neuronal form again, where it does not help and should not be offered. So it's very important to categorize the disease correctly and then offer to the right category of the lysosomal disorders to have the benefit of transplant. Again, leukodystrophies. X-linked adrenoleukodystrophy is most common neurogenetic condition. The males, metachromatic leukodystrophy. These are again conditions where transplant can be curative and should be employed, especially before neurological damage sets in. Macrophage disorders like primary HLH, congenital neutropenia. Dr. Anand is going to talk about HLH, congenital neutropenia, reticular dysgenesis, leukocyte defects, Shiraki-Higashi syndrome, CGDs, Griscelli syndrome. These are all like tongue twisters. We don't see them that often, but then we do come across occasional patient, and this itself becomes a very big group of diseases where transplant again is of curative option for them. Again, bone marrow failure syndromes, Fanconi anemia being the commonest, followed by Schaumann, Diamond, and Discourse congenital. Fanconi anemia is very common, and especially in our part of the country where a lot of consanguineous marriages are there. So South India, we see a lot of Fanconi anemias, and this being the only curative option for this group of conditions as well. Now, before I conclude, I just want to spend a couple of times with thalassemia major, because thalassemia is we are the thalassemia capital of the world. We have 10 to 15,000 thalassemics born every year, and transplant is one of the curative options. Of course, gene therapy is also been for that now. That's not available in India at this point of time, but can be used also as a curative option. Now, for thalassemia, if you see the thalassemia history, the first transplants of thalassemia were done by Italians, and they started transplant program in 1981. They followed about 900 thalassemia patients over a period of about 20 years and saw that quarter of the patients would be cured with stem cell transplantation in that cohort. They also followed the patients who did not have transplants in this red line. Those who didn't have transplant either didn't have a donor or they were not willing for a transplant. We saw after a 10-year follow-up, less than 20% patients were still alive and well. This was kind of proof of the principle that thalassemia is curable and a majority of the patients can be cured and given a good quality of life. But what also Italians showed us that, thalassemia is not one disease. It's actually 3 diseases. If they're well managed, no liver enlargement, no fibrosis, they're very well chelated, it becomes class 1 or low risk disease. But they will have big liver, there's portal fibrosis, that they're not chelated very, very well. It becomes class 3 disease, and something in between is called as class 2. Now, why this was important? Because when you look at the class 1, around 90 to 95% patients could be cured in the patient who were less than 17 years of age. And class 2 was in between. It was about 85, 86% patients could be cured. And the class 3 was the least, which was 75, 78% patients could be cured. This is just to show same set of doctors, same set of disease, but same kind of conditioning was used. And if you see just being what kind of class you are, if you're managed well, your outcomes can be as high as 95%, but if you're not managed well, your outcome can be as low as 75 to 78%. What's been our experience with thalassemia at our center? This is a little older data we am presenting here. We had about 36 class 1 in that time in that cohort, and 95% were thalassemia-free survival, or 34 of the 36 patients in this cohort had cured of thalassemia. Class 2, class 3, that's the problem. In our country, we see mainly advanced thalassemics, more in class 2 and class 3s, about 300 odd patients at that point of time we analyzed. And in this cohort of patient, the overall survival and event was 85 to 89%. So this is exactly what Italians had showed in their date experience as well. And we had seen similar experience in our center with class 1s doing more, better than 95%, and class 2, class 3 in the range of 85 to 88, 89%. So in India, we, as I said earlier, we're the thalassemia capital of the world. We have about 40 million, 4 crore people carriers of thalassemia. 10 to 15,000 are born with thalassemia every year. If we do 1/3 of these patients have a fully matched donor, that means for thalassemia, we require 3,000 transplants for matched sibling donor transplants every year. And how much we do all the centers put together, 300 to 400 or 500 transplants. So this long way still to go in for thalassemia in our country. In our center, we have about 2,500 transplants till now. Being a referral center, we do mainly allogenic and haplotransplantation for all the indications which I showed you before: leukemias, lymphomas, as well as aplastic anemia, hemoglobinopathies, as well as immunodeficiencies. This being our experience in 2023, we do more than 200 pediatric transplants at our center. Some of the things which have happened in the latest in the transplant world is that we are The transplants are becoming more and more safe with the use of this reduced intensity transplant conditioning. These are the new medications which have come up, making it more safer. Increasing recipient age doesn't apply for pediatric practice, but in adults, of course, previously they will not transplant patients more than 55 years of age, but now with the again with the safer conditioning age regimens, they can transplant now to 60, 70 years of age as well. Virus stem cell source, I told you, full match donor, we can find only 25% of the patients. Maybe 10% of the patient we can find an outside donor called as unrelated donor. But then 60% of the patient who didn't have any option previously, but now with use of half match donors, which was one of the kids in 2013, we started our half match transplant program in Karnataka, and this was the first child who had leukemia and transplanted using haploid transplantation from his father. And I also showed you a lot of non-malignant indications for transplant, especially pediatrics, which are not cancerous, but then equally dangerous, I would say. For some of the students who may have logged in, half mesh transplant is the problem with half mesh transplant has been fighting off these donor cells with the patient, and that's called as graft versus host disease. That can be countered with one of the graft manipulation techniques. We have got T cells which mediate this graft versus host disease. And T cells actually are alpha, beta, gamma, and delta. The gamma, delta, the good ones, the alpha, beta, the bad ones. These T cells we can remove from the graft called alpha, beta depletion. And we have done more than 400 transplants using this technique in our center. One of the largest Asian experience of doing these kind of haplo transplantation. This has made the transplant, more safer, I would say, with this more sophisticated way of removing the cells which can lead to graft versus host disease. So before I conclude, a lot of challenges though. I discussed a lot of history, science, and indications, but a lot of challenges. Delayed referral is one of the challenges. That there are typical examples of delayed referral is thalassemia major. I showed you how thalassemia major class 3 do not do as well. Immunodeficiencies can come sometimes very, very late, and you can't do much about them. They may not have an option of transplant because of the comorbidities they have or infections they carry. Aplastic anemia is another example where referral can happen late and you can't do much for those patients as well. There's a lot of limited resources. It's an expensive treatment, and as we know in India, it's most of them out of the pocket expenses. Drug availability not a huge concern now in India. Manpower it's a game actually played by the nurses, so we require very skilled nurse power. Nursing skill to help these patients during the transplant program. I also told you about the unrelated donors. So we need a lot of people on the donor registries to be able to have a patient with a matched unrelated donor. In our registry, we have about 5 to 6 lakh donors compared to German registry, for example, who has about almost 10 million donors on the registry. So that's why finding a Caucasian patient, a full match donor is very easy, but finding for our patients, a full match donor is difficult because it also depends on ethnicity, chances of finding a match. This is our transplant center at Bangalore, and as I said, nurses are very, very important. These patients are kept in these positive pressure HEPA filtered, nursing units, and 1:1 nursing is very, very critical to prevent infections and provide other care during this phase of profound neutropenia, profound aplasia. And some of the patients some of them are still in the unit, some of them getting discharged from the hospital. We have very strong international collaboration. We have transplant patients almost from 50 countries. And this is my last slide, and this is when we complete 2,000 transplants. They're very, kind of picture very dear to me. If you see some of the children here, some of them are still young, some of them grown up into adults now. So outcomes of pediatric transplant pediatrics is really good. More than 80 to 90% of the patients from non-malignant diseases and almost 70+% patients of malignant disease can be cured and cured forever, and they bounce back very, very fast, and then almost lead a normal healthy life like any other child in the community. So thank you very much, and I'm sincerely apologize again for the network issues I had throughout this presentation, and I can take any questions if any of you have. Thank you very much. Thank you, Dr. Manit, and apologies again.
Thank you, Dr. Sunil. Despite the constraints, you managed to give us a good presentation. It sounds very exciting and a successful story, the whole journey of transplant. Generally, we have a format of accumulating questions by the end of both the presentation. I understand that you wouldn't be possibly available until the conclusion of the session. If we are still there. I do not notice any questions as of now. So just a quick run as to what are the common indications that you are handling the transplant, uh, bone marrow transplants for.
Transplant indications, if you see at the non-malignant indications, in our country, thalassemia is the largest indication. Almost 33% patients we transplant are thalassemia major, just because the burden of the disease is that much, and also availability of support systems for them through the government and other agencies. Then we have second commonest would be bone marrow failure syndromes, whether it's aplastic anemia or anemia, that becomes another common indication. And then the rest of the common indications would be immunodeficiencies and other storage disorders, which I was mentioning. In malignancies, ALL, acute leukemia, and AML are the two commonest indications for transplant, allogeneic transplants. And autologous transplant in children, the most common indication is neuroblastoma, actually, what we call as high-risk neuroblastoma, wherein the chemotherapy itself is not enough, so we need to give them what we call as high-dose chemotherapy and stem cell rescue, and that's autologous transplant done for neuroblastoma. That's the commonest indication for autologous transplant in children. In adults, for example, autologous transplant is commonly done for multiple myeloma, but we don't have that problem in children. So in children, it's mainly hemoglobinopathies, thalassemia, sickle cell, bone marrow failure syndrome, which is aplastic anemia, immunodeficiencies, and storage disorders in non-malignant and malignant leukemias and lymphomas, and also some cases of neuroblastoma and other rare malignancies. Thank you.
You may be aware this is our population problem too. Thalassemia is kind of our population problem too. I mean, Bahrain.
Bahrain, yes.
We have a good premarital screening plan, and that has had a good impact on reducing the thal major incidence here. What would be your message to the pediatricians? What would be the optimal window? I think different indications would have a different window of when they could be referred. And as always, we would have this question as what would be the probable cost of the whole procedure, and how would we involve pediatrician after transplant? When would be our role again to care for in a post-transplant scenario? Roughly, if you can give us an overview before we move on to the next.
Sure. So it's a good question, and actually, three questions actually there. One is, what is the message for the pediatrician? So I think one is that stem cell transplant is a reality. A lot of centers do it, and there's been a tremendous, I would say, success improvement over a period of time. Donors, not a problem now. We can do transplant directly for any patient, irrespective of the donor type. So identification of these patients early is very important. And I think that's why I mentioned in the last slide, challenges delayed referral, especially for conditions like immunodeficiencies, aplastic anemia, wherein, you need to quickly pick them and then transplant them. Because sometimes, you've got immunodeficiency diagnosed, but then they're having a very bad CME infection or a bad disseminated, tuberculosis, then you really cannot do much. So early identification of some of these conditions, which we discussed here, and having that conversation with the hematologist is of utmost importance to identify them early and treat them early. Second was about the cost. Costing depends on the type of disease, the type of donor. And now I know it's going to be a mixed audience here, but if you look at our country, for example, a full match donor transplant, if it's a allogenic transplant, will cost anywhere from 12 to 14, 15 lakh rupees. Unrelated donor transplants and haplotransplants are a little more expensive, maybe around 18 to 20 lakh rupees, because they stay in the hospital a little longer, the medication is a little different. But having said that, there's a lot of support systems available now. In our own country, for example, thalassemia transplants are covered if they're less than 12 years of age by a scheme from the government. There are Pradhan Mantri Relief Fund. There is a lot of NGOs who have come forward and support. So I actually personally feel that if the family is committed, there is not going to be a problem of funding that much. It's going to be, it can be managed somehow from various resources which are available at this point of time. The third, again, very important question is how can the pediatricians can be involved after transplant. See, we can we have to understand after transplant, these patients are immunosuppressed or compromised for few months to almost a year post transplant. By 1 year, as I said, we start the vaccination. So the pediatrician will be involved in vaccinating the children after 1 year. Those protocols are available through IAP, or we also give the patients when they go back to the communities those protocols. So that has to be executed after 1 year. That the pediatrician usually does it when they go back to the community. Also, we keep them in the vicinity of the hospital at the transplant centers for almost 1 or 2 months post transplant. But again, after that, they'll go back to the community. And as I said, they'll be still immunocompromised for a few months to a year. So during that time, the pediatricians are again involved in looking after them for for routine checkups for any infection which comes up, which can be managed locally. Sometimes you may have a herpes infection. You may get a upper respiratory infection, which of course in immunocompromised patients can sometimes be troublesome. So that's something which has to be managed in the community level. The pediatricians can do that in the immediate post transplant period. Also, any complication which has come up later on after they go back to the community, like graft versus host disease, and having that conversation with the transplant center or the hematologist ongoing is very, very essential till they, kind of overcome these problems and, go back to the society. So pediatrician, of course, is very important in the post-transplant care as well. Thank you.
Thank you very much. A couple of information which you gave are very reassuring. We will, as we always say, the perk here is the contact information that we have about the physicians who give the talk, and we will channelize the questions if any come by later to you for personal answering, doctor. Thank you very much. It was a very, despite all the difficulties, you managed to deliver a very useful talk to us, and our sincere gratitude for that also.
Thank you.
Now,
Thank you very much,
I will,
Vanita. Thank you.
thank you. So we will proceed to the next talk. This, as we know, the theme is hematology. We have another eminent hemato-oncologist from India, Dr. Anand Prakash. Dr. Anand Prakash is the lead and head of pediatric hemato-oncology and bone marrow transplant unit of St. John's Medical College. And he was supposed to be the lead delivering expert, but then because of the constraint, we managed to swap the talks today. Right now, this would be Dr. Anand Prakash delivering pediatric HLH, the current concepts. We know HLH is a mimic of most of our emergency encounters in pediatrics, and we will hear about what are the revisions and current guidelines as regards this, and how the trajectory of our diagnosis will make a big difference. So over to you, Dr. Anand. Please, the platform is yours. Please get started with your topic. Thank you.
Good evening, Dr. Vanita, and thanks to the IAP group, the IAP Bahrain group, for this wonderful opportunity. I remember speaking to Dr. Pejawar and also chatting with Dr. Vanita on email while we were deciding what topic would be relevant to a group of pediatricians. And I'm glad we chose HLH because I think, like you rightly said in your introduction, HLH is something which general pediatricians, pediatric intensivists, neonatologists, people working in pediatric gastroenterology, perhaps people working in definitely pediatric rheumatology. Of course, pediatric hemonc doctors do see HLH patients. They are referred sometimes for primary HLH in terms of transplant. So I think this is a topic which all of us should know about. So what I thought I'll do over this presentation is first of all tackle the question of why should I know about HLH? Because sometimes when working in general pediatric practice, we would feel that is this something very rare? Is there something which I really need to know about? And we'll go over some of those aspects. We'll, of course, go over when we should think about HLH, how we evaluate for it, and of course, the key concept of how we treat. So I think the key message, and I'm sure many of you are always aware that this hemophagocytic lymphohistiocytosis, it's a mouthful, but it's something which is life-threatening. And unless you and I in practice think about it, unless we have a low threshold to suspect it, and unless we consider that this requires urgent treatment, we are going to lose a lot of patients. So the big challenge remains as to which of these patients actually are HLH, because the second point, many underlying causes actually trigger HLH. And these underlying causes are important because there are some underlying causes which don't require extensive treatment, whereas others do require very specific treatment. So first challenge is, when do I suspect? Second is, what is actually triggering this whole process of HLH? And I've got a few interesting cases because I work in a large academic hospital. And because HLH is so common nowadays, we get a lot of referrals from our colleagues in pediatrics, pediatric intensive care, neonatology, and many times the question is this HLH? Do we have to use the HLH protocol? Do we really need to give etoposide? Do we need to be aggressive? Should we consider transplant? These are the questions which come up. And so while, yes, we should have a low threshold to suspect HLH, we should also remember that there are many mimics of HLH, and we don't want to overtreat a patient. We don't want to scare them and say, perhaps your child needs a bone marrow transplant unless they really need it. And this is the fourth point, I think, is also very critical, in that usually we are taught in medical school that first we evaluate and then decide what is the therapy and then start treatment. In fact, this is true even for dangerous diseases like leukemia. Unless we know the complete diagnosis, we can't treat the patient. HLH is a bit of an exception to this rule because once you start suspecting HLH, you can't really wait for all the labs to come in to say, okay, I'm going to start some therapy. So this is one of those challenging areas where treatment and evaluation perhaps should go in tandem. So we'll look at some examples regarding these four areas. So again, coming back to the key question of why should I worry about HLH? I'm sure as pediatricians, hematologists, intensive care doctors, fever is one of the commonest symptoms which you and I see. The challenge for us is which one of these fevers is HLH. I'm sure we'll see a lot of sepsis. So perhaps one of the take-home messages is any sick child with fever who is rapidly going into organ dysfunction. We all see children with dengue. We all see children with, let's say, pneumonia, sepsis, septic shock. But let's say a child is not responding to treatment, very rapidly is getting sicker and sicker in the ICU. There we should have a low threshold to think about HLH. And the key message, of course, I'm sure many of you are already knowing this, is that unless we have urgent suspicion, evaluation, and tandem treatment, urgent therapy, we are probably going to lose these children. And so undiagnosed HLH or late diagnosis with multi-organ dysfunction, I'm sure we all know the surviving sepsis guidelines. So just like in sepsis where we need urgent diagnosis and urgent initiation of treatment, HLH is one of those. And if you and I think of it in the right children with fever, cytopenias, we'll come to some examples, I'm sure we're going to prevent mortality. So often missed or late diagnosis, I'm sure pediatricians are the key for early referral and early diagnosis and suspicion. So what is HLH? HLH is a life-threatening hyperinflammatory syndrome. The hemophagocytosis in the term HLH is an end result of this hyperinflammatory syndrome. And why is there hemophagocytosis? Because there is uncontrolled immune activation, right? So the whole term of hemophagocytic lymphohistiocytosis, again, it's a mouthful, tells us that the immune system is not working like it should. So what is the normal immune system supposed to do? The normal immune system, like you and I already know, have a lot of cells, the NK cells, the T cells, the phagocytic cells, which are the monocytes, macrophage system, are all supposed to work in tandem, and they all are supposed to work with a negative feedback. They're supposed to do their job. If there's an, let's say, a bacterial infection or a viral infection, sort out that infection and then stop working. The normal immune system is always produces cytokines. Even as undergraduate students, I'm sure we know that fever is because of inflammatory cytokine release. And so the normal physiological cytokine release and phagocytosis is all part of the normal immune system. So what happens in HLH? It's a disordered immune system. It's an immune inflammatory system. It's also called an immune dysregulation. And so what tends to happen is that this abnormal immune system does not know what to do with the usual insults which you and I will probably, tackle without going into full-blown HLH. So what are the common triggers? Common infections could trigger this underlying abnormal immune system to cause a lot of cytokine release. There is no negative feedback, and so the monocytes and macrophages, which are supposed to, their job is to cause phagocytosis, they continue to cause uncontrolled phagocytosis. The cytokine release, which is supposed to stop and have negative feedback, doesn't happen. So there is a persistent, uncontrolled immune activation. And so if you have, I'm sure all of us have seen COVID and how so many of the COVID patients had uncontrolled cytokine release and really became sick very quickly. So in that scenario of uncontrolled cytokine release, we have a HLH endpoint, which is a very sick patient with cytopenia, prolonged fever, and organ dysfunction. So this is a nice cartoon from the NEJM, and the author is Jan Inge Henter. He's perhaps one of the leading luminaries in all the work done in pediatric HLH. So the top part of this picture shows us how when a normal person has a infection which comes in to antigen presenting cell, the macrophages, the NK cells, and the T cells work in tandem, and they have controlled cytokine release, right? And there is a negative feedback to control the immune system. In patients with HLH, all of these systems start working, but there is no negative feedback. And so, like I mentioned, you have a cytokine storm and you have the end result of uncontrolled monocyte macrophage function. This is a cartoon which nicely shows that between the target cell and the activated T cell, how there are various processes which are supposed to happen. We heard in the first talk how many of the immune dysregulations like primary HLH, perforin mutation, Chediak-Higashi, Griscelli syndrome, in all of these, there is a uncontrolled immune reactivation. And so at any point where there is no control of the immune system, if there is a mutation, these are all types of primary HLH, the child lands up in a difficult situation. So I mentioned the term primary HLH, which in some situations is also called familial HLH, because clearly this is a genetic disorder. This is a situation where most of these are autosomal recessive. I'm sure many of you would have heard of the perforin mutation, monk mutation, syntaxin mutation. All of these are inherited. Other group of primary HLH is Chediak-Higashi, Griscelli, and Hemansky-Pudlak, which are all situations which present in early infancy or early childhood. I would like to caution the viewers here that other inborn errors of immunity can also present as HLH. So, for example, Dr. Sunil started off his talk with a child with a T cell immune dysregulation. So, severe combined immune deficiency, for example, chronic granulomatous disease, for example, Viscott-Aldrich, for example, can all other types of primary immune deficiency can also present to us as HLH. What about the other group or acquired or secondary HLH? We must recognize, and I'm sure many of you would have seen this in practice, is that when you have certain infections, the common ones for you and me would be EBV and dengue, sometimes underlying malignancies, sometimes autoimmune diseases. Could I please request the participants to mute themselves so that we are better
There's a
heard?
participant, Deepthi, who is unmuted.
Could I
Miss
request to
Deepthi, can you
mute,
please
please?
mute yourself, please?
Yeah, thank you. So when you have underlying infections, so these are the three groups: underlying infections, malignancies, and autoimmune diseases. When you have these three groups, they are underlying diseases which are not primary HLH, but would present with the same final common pathway of a cytokine storm. This includes, so rheumatologists would always call HLH macrophage activation syndrome, which would be seen in systemic JIA and SLE. So I'm sure you recognize that HLH is a clinical syndrome with diverse triggers. And so it is not just a single disease. So this
I
cartoon
request
is
a
quite
minute of
useful
pause,
to,
doctor.
sorry.
Miss Deepthi, you are unmuted. Can you please mute yourself? It's interrupting the talk. Mrs. Aji, can you mute them all, please? I don't.
That's okay. When
I'm
your
sorry,
coordinator
doctor.
does
Can
that,
you
we can
proceed?
go ahead. No worries, no worries. So I
Please go
think
ahead,
this
doctor.
is an important slide because it tells us that under the common umbrella terminology of cytokine storm, you have so many of these entities. Primary or familial HLH is just one small group in this small blue circle. There are other entities of infection associated HLH, COVID related HLH, EBV related HLH. The rheumatologists would look at this as macrophage activation syndrome. Some malignancies like leukemias, lymphomas, particularly the T cell lymphomas, can come to us with as a first presentation as HLH. And so all of these would fall under the umbrella term of cytokine storm. So there is this old Indian story, I'm sure many of you are aware, of many blind men touching an elephant. So once we start understanding the underlying histopathology and the pathology and pathophysiology under all these diseases, we'll probably recognize that there are various triggers. The pathophysiology ultimately lands up with a common final pathway. And so because there are various triggers, the underlying therapy would vary. And because these underlying triggers are different, the prognosis varies. And so when you have a patient with HLH, recognizing that this patient is having HLH is important. And secondly, recognizing what is the possible trigger, that also is very, very important. Because if the underlying trigger is malignancy, we have to quickly diagnose it and treat the malignancy. If the underlying trigger is an infection, let's say dengue, we have to treat the dengue along with the HLH. And let's say you have a scenario where you're worried this is primary HLH, then the therapy totally differs. So the first question for us is this HLH? The second question, is this primary or secondary? And I'd like to point out that historically, while people used to try and draw clear distinctions between primary and secondary, now the distinction is getting blurred. And for you and me at the bedside, this distinction is not always straightforward. Sometimes this distinction is understood only after the disease evolves. So, what do I mean by that? If you have a child who fits into this green box here, who's very young, less than 2 years of age, there is a history of consanguinity, there is previously a sibling death due to, let's say, sepsis, unknown causes, a previous sibling who's died of, let's say, acute liver cell failure, no clear diagnosis, a child who presents very sick with fever, has undiagnosed CNS symptoms. So let's say you have a child who comes in with fever, seizures, and straightforward pyogenic meningitis. You're not going to really say HLH. Whereas if you have a child who comes in with fever, cytopenia, has seizures, the neuroimaging shows non-specific white matter changes, the child has a splenomegaly, ferritins are high, those are the scenarios where you will think, yes, this child has primary HLH. And we've spoken about some of the common syndromes and the mutations. The secondary list, like I said, is a huge list. I've listed out some of the primary immune deficiencies which can present with underlying HLH. And like I said, this distinction is becoming blurred. Why is this distinction becoming blurred? Because many of these secondary HLHs are now known to sometimes have a heterozygous mutation of one of the primary HLH syndromes. So it's not always easy to differentiate primary from secondary HLH. To add to this difficulty, with more and more genetic evaluation happening, there are newer entities which are coming up. And these are some of the newer entities which have been described, all of which are diagnosed not clinically, but by next generation sequencing when we do an exome for evaluation of a child with underlying HLH. And some of these are particularly susceptible to EBV. Historically, X-linked lymphoproliferation was well known to be an EBV-triggered HLH, and now there are a host of new underlying mutations which may suddenly come up in a child who has presented to you with HLH. So knowing the underlying genetic diagnosis is critical. We had the talk on transplant. So recognizing if there is any of these underlying primary HLHs, which is well known, like perforin, monk, syntaxin, Griseli, Cheriac, Higashi, or some of the evolving ones, which are EBV susceptibility disorders, are all critical to decide, does this child really need the HLH to be controlled and then to go for transplant. So let's quickly go over the clinical presentation. Most of these patients, I'm sure you know, present with unremitting high-grade fever. One clue to differentiate these patients from truly septic patients is that some of these patients, even though they have high fever, are relatively active, whereas the really bacterial sepsis children, I'm sure you would have all seen, are really unwell. They're very irritable. They look unwell. Whereas some of the primary HLH children, though they are spiking fever, would remain relatively well looking. Hepatosplenomegaly is an important clinical finding in all children with HLH, primary or secondary. And it's also more and more recognized for the last decade that a proportion of children, particularly in infancy, when they present with fulminant hepatic failure with no other obvious cause, HLH should be a differential. Just last week, we had a child referred from Chennai who initially presented to the tertiary care center with fulminant hepatic failure and later had a cytopenia. And the underlying genetics showed a UNC mutation. So fulminant hepatic failure could be an initial presentation. Cytopenias, initially starting with bicytopenia, rapidly progressing to pancytopenia. These are patients who, let's say you have a fever, you have cytopenias, let's say platelet count is 5,000, you're worried this is a sick child, you transfuse platelets. Because of the active hemophagocytosis, many of these children, the platelet recovery or the repeat count after giving the platelets will be really very low. Just like you would see, let's say, in a child with DIC or in a child with immune thrombocytopenia. So if you have refractory cytopenias, that's a clue for HLH. Neurological symptoms particularly gives us a clue for primary HLH. Some of the important red flags when you and I work, because sepsis fever, like I mentioned, is very common. If there's a persistent fever with cytopenia and high ferritin, the criteria talk about a ferritin of 500. The higher the ferritin, the higher the risk of this child having HLH. And there is data to show that if your ferritin is more than 10,000, the chance of you having a true macrophage activation is very, very high. Some of these children actually get better with supportive care, but come back over the next few weeks to months with a repeat episode of fever and cytopenia. These are the children where we should have a low threshold to say, why is this child with every fever having cytopenia? Usually with fevers, you should have a high white cell count with a neutrophilic predominance. So if you have a low white cell count, then that should cause a red flag. A rapid deterioration with multi-organ involvement. I'm sure all of us treat a lot of dengue infection, but if you have a child with dengue going into multi-organ dysfunction rapidly, these may be the children with a secondary HLH. Non-response to routine sepsis treatment, a family history of sibling deaths, and a family history of consanguinity. All of these would be red flags in this setting of sepsis and cytopenia. So these criteria have been commonly talked about. All of us know about the 2004 criteria. What I'd like to stress is that these criteria were formulated by the Histiocyte Society to, to get a group of patients which are having the similar phenotype. These were not criteria to be used to say that this child has or does not have HLH. So very important to recognize that the criteria were made for uniform diagnosis, but not all patients, when they initially present to us, may fulfill all of these criteria. A lot of the time, pediatricians tell us that, should I do a marrow to look for hemophagocytosis? Well, yes and no. For example, when you do a marrow, if you find hemophagocytosis, it's a clue that yes, hemophagocytic syndrome is going on. But the absence of hemophagocytosis does not rule out HLH. In fact, you do a marrow in this setting of fever, cytopenias, organomegaly to rule out other conditions, commonly leukemias, lymphomas, which would mimic a HLH. The recent criteria talk about HLH 2024 criteria, where because NK cell activity is not easily available, it was removed. And so the current criteria talk about meeting 5 out of 7 to label a child as having HLH. So the take-home message from this child is that if you have a child with not yet meeting 5 out of 7, but looks like the child is evolving to meet 5 out of 7, then we should have a low threshold to keep a watch for this child deteriorating into full-blown HLH. So clearly making the diagnosis is not always easy. So people have come up with things like H score. You could do a flow cytometry to look for perforin levels, granzyme levels, and flow cytometry is also useful in SAP and XIAP. But all of these children, particularly when you have a doubt, very, very important to quickly send off a next generation sequencing. Because not only does it help us confirm the diagnosis, I'm not saying you wait to get the report you have to treat and wait for the report to decide what are you going to do with this child with HLH. Is this the child who needs to go for transplant? Is this a child at risk for a repeat episode of HLH? Or was this plain and simple infection triggered HLH? So to plan further therapy, NGS is very, very critical. Our future episodes likely, and very, very important, particularly if this family has lost a baby. If this child is looking like you can't pull out this baby from your ICU, you may not really get this child out of the severe HLH. Important to do an NGS in this very sick child so that for the next baby, the family is able to do a quick genetic diagnosis, sometimes antenatally, so that they are prepared and they know what to expect. Because many of these are autosomal recessive, and I'm sure we recognize that there is a 25% risk of recurrence of primary HLH. Like I mentioned in the previous slide, hemophagocytosis on marrow is part of the criteria, but is not mandatory and not specific at all. So what are the management principles? all of you would have seen this HLH 2004 protocol, which talks about immediate stabilization. Most of these children need to be in the PICU. We need to look for all types of infections which could trigger the HLH parallelly. Bacterial infections can, viral infections can. If a child, has had multiple infections in the past, this child could have an underlying primary immune deficiency. So look carefully for infections and start empirical treatment like you would in any child with suspected sepsis. The HLH specific therapy starts off with steroids, which primarily is dexamethasone in the hematology world and methylprednisolone in the rheumatology and the ICU space. If you are dealing with a primary HLH, etoposide plus minus cyclosporin is part of the standard HLH protocol. Most children with primary HLH do not settle down with only steroids. So while yes, there is always that challenge, does this child really need etoposide? It's a chemotherapeutic drug. I don't think in a rapidly evolving sepsis-like situation where there's been a previous sibling death, or we know that this child has Griscelli, Chediak Higashi, we know that this child has perforin mutation, there should be any reluctance with using etoposide. If you're dealing with a child with underlying SLE, or you think that this is systemic onset JIA, in that space, the rheumatologist would use, IL-1 inhibitors like anakinra. IVIG along with methylprednisolone is the way to go ahead. If EBV is the trigger for HLH, rituximab should be used along with steroid therapy. And when you have genetic diagnosis, after the HLH is under control, you would consider transplant as a definitive modality of treatment. Because if you just get the HLH under control and don't do a definitive transplant, this is not a child who is going to survive for long. This is a child who's going to have a recurrence of HLH, and then maybe it is too late to do anything. The most recent papers on HLH talk about how immunomodulation has come a long way, and there are a lot of targeted therapies for HLH which are evolving. So what are these targeted therapies and what are the changes and evolving therapy options for HLH? Remember that for many of the infection-related HLH, sometimes steroids alone, and particularly in the dengue-related HLH, there are a lot of experience, I'm sure, from many centers, and we have a lot of experience with using steroids alone in dengue-triggered HLH, sometimes lower doses of steroids for a short duration, just to get the cytokine storm under control. And many of these patients who otherwise would probably have gone into severe multi-organ dysfunction, who are already in multi-organ dysfunction, rapidly recover. Particularly in infants, the old protocols talk about the high dose of 150 mg per meter squared of etoposide, particularly for infants or with those with culture positive sepsis with coexisting HLH. You could use lower doses of etoposide, something like 50 to 75 mg per meter squared. There is evidence for using lower doses. And there are a lot of exciting developments in terms of cytokine directed therapy. Just like in COVID, tocilizumab became the go-to drug for a lot of difficult to control cytokine storm in COVID. In HLH, infection triggered or otherwise, anakinra and emapalumab are the new drugs. Anakinra has been around for a long time. Rheumatologists are using it very regularly. So this is this? This is an IL-1 receptor antagonist. It blocks both IL-1 alpha and IL-1 beta, which are both key drivers of the hyperinflammatory response. So unlike steroids, which cause immune suppression, which suppress not only cytokines, they also suppress good T cells, which are helping us to fight an infectious trigger. Anakinra blocks only these IL-1 receptors. So particularly for children who have a bad bacterial sepsis, you are having a coexisting HLH going on. This is one of the drugs which has been found to be very, very helpful. So it's given by subcutaneous dose. and you decide how many doses you need quickly based on response. Emapalumab, there's emerging evidence. There's very nice paper in NEJM talking about this drug. And what is it? It's a human monoclonal antibody for interferon gamma, another key, cytokine which would trigger and cause progressive HLH. So particularly in refractory, recurrent, or progressive disease, this is a monoclonal which would be very helpful. Interferon blockade can impair immune responses. So unless you really have a situation of difficult to control HLH, this is something which should be used. So what is the prognosis and follow-up of these children? The prognosis clearly depends on what is the underlying cause, promptness of diagnosis, and in familial HLH, the genetic group availability for transplant. How do you monitor these patients? Once you start the HLH therapy, clearly you monitor ferritin, you look at serial CBCs for children with liver dysfunction, you look at serial LFTs, you look at triglycerides. So the CBC, ferritin, and triglyceride trend will give you a clear indication whether this child is responding to therapy. In most children with HLH, you do need to screen for relapses. So once you start bringing down the immune system, when bringing down the dose of steroids, you do need to look for relapses. And genetic counseling of families is very critical. So I'll present a few cases now which will tell us as to why we should be careful before jumping to the diagnosis of HLH. This was a 10-year-old boy who came to us with 10 days of fever, empirically treated with ceftriaxone. He did develop mild cytopenias. His ferritin was on the higher side. He was related to, one of the senior members of parliament. So a lot of anxiety, not only in the family, but also in the treating team. And so because of the cytopenia, the primary pediatrician went ahead and did a marrow, which showed hemophagocytosis. So is this HLH? By the time he was referred to us, his fever had settled. He had spontaneous recovery of counts. His ferritin had nicely come down to 800. And so this was probably just typhoid, enteric fever, and he completed his course of ceftriaxone. So though this child had hemophagocytosis, this did not require full HLH treatment. Another patient, a 12-year-old boy, fever on and off for 3 weeks. He came in with generalized small lymph nodes, hepatosplenomegaly. He did have cytopenia. His ferritin was quite high. It was 3000 this time. Most of his infection workup was negative. Patients are very anxious. 3 weeks of fever. I'm sure all of us as parents would be anxious. So the primary pediatric team was keen on starting HLH treatment. After all, the ferritin was so high. His fever is not settling down. No obvious infection. He was referred, and a lymph node biopsy here showed us Hodgkin's. Many of these patients would have cytopenias, would have high ferritin, so we shouldn't rush in to treat with steroids. What would have happened if we had blindly treated this child with Dexa and etoposide? He would have got better for some time because the underlying disease process was Hodgkin's lymphoma. So for a child with suspected HLH, looking carefully for leukemias and lymphomas is very critical. Third patient, 12-year-old girl, we have a very big pediatric nephrology department who works with us. CKD planned for a renal transplant, low-grade fever and cytopenia for 2 weeks. Infection workup was negative. Ferritin is 3,500. Is this HLH? Should we start on steroids? Extended workup showed a CMV. Responded very well to ganciclovir and GCS. So here again, unless we do extended viral panels, blindly giving steroids would have just caused this child to flare up the CMV and make this child sicker. Again, next example, 5-year-old boy, fever for 15 days, otherwise well, no focus of fever, no response to antibiotics, developed pancytopenia, had hepatosplenomegaly, ferritin again sky high at 5,000. Marrow showed B cell ALL. So again, point to be noted that just because you have a high ferritin and pancytopenia and hepatosplenomegaly, unless you have the whole clinical picture fitting into HLH, we should not rush into giving steroids. Another example, 3-year-old girl, fever for 5 days, dropping platelets, LFT is deranged, NS1 positive, referred for respiratory failure, shock, and worsening transaminitis. Ferritin is very, very high, 45,000. Remember, I said whenever it's more than 10,000, very likely HLH. Rapidly recovered with DEXA, broad spectrum antibiotics, and supportive care in our ICU. So, this was an infection triggered HLH and perhaps does not require any further invasive therapy. This is a paper from our unit which looked at all our infection related HLH. I know the text is very small, but just drawing your attention to this pie chart at the bottom, a large proportion was dengue related HLH, and infection triggered HLH also, if not picked up in time, can go into multi organ dysfunction. So, those who had multiple organs involved. So, what we showed was that if there's CNS involvement, renal involvement, and a high PRISM score at diagnosis, then many of these children do succumb. I'd just like to end up last few slides giving you some flavor of transplant in HLH. This was a 3-year-old girl who presented to us with PUO, had light colored hair. She had Chediak Higashi, treated on the HLH 2004 protocol. Very difficult to control HLH. In fact, we has had to use ATG and ruxolitinib to get her HLH under control. Went in for a matched unrelated donor transplant. Remember from Dr. Sunil's talk, she didn't have a brother or sister donor. She was the first child. Parents were not fully matched. We were fortunately able to get an unrelated donor. Had a peripheral blood transplant. Had the usual complications post-transplants, many infections. Fortunately, she came out of all this, had mild skin and gut GVHD, and required a prolonged course of steroids and Ruxo post-transplant. Initial pictures post-transplant, and there's happy child 3.5 years post-transplant. So a primary HLH, not easy to treat, difficult to get HLH under control. But as soon as the HLH is under control, we should quickly move in for transplant. This is a picture I like to show in all the talks. A story, I call it a story of a family photo. This little boy came to us with, he was born to secondary consanguineous parents. He had prolonged fever for 1 month, low counts, hepatosplenomegaly, and light colored hair. So our colleagues in pediatrics itself said, does this child have, you know, does this child have a RAP2 mutation? And yes, he did have this mutation. And fortunately for him, his father was the donor. His sibling also, when we screened for a donor, had the same mutation. So both children have the same disease, and the mother was a full donor for this child. So both children went in for transplant. The mother, the donor for the first child, the father, the donor for the second, and both children fortunately are completed their transplant and are doing well. So which ones need transplant? The primary HLHs need transplant. Some of the patients, you may do an exome, and if you have a very young patient with recurrent episodes of HLH, if you have a strong family history of death due to what looked like sepsis bar HLH, if you have recurrent HLH, these are the patients who likely need to go for transplant. And in a proportion of these patients, if you get a known mutation, well and good. But if you don't get a known mutation, you may have to have a detailed chat with the family and say that before this patient has a repeat episode of HLH, we've got the HLH under control now. Let's quickly go for a transplant. So what are the take-home messages from my presentation? I'm sure I've convinced you that HLH presents to many pediatricians in different ways. It is a pediatric emergency, and whenever you have fever of unknown origin with cytopenias, rapidly going into organ dysfunction, recurrent episodes with fever with cytopenias, unexplained CNS manifestations, think of HLH. Do not wait for hemophagocytosis in the marrow to start treatment, but if there's a doubt that there may be underlying leukemias, lymphomas, doing a marrow is critical before blindly starting every child with fever and cytopenia and a high ferritin on steroids. A ferritin more than 10,000 should raise red flags. So if you have a sick child, call in your hemonc colleagues, call in your rheumatology colleagues, and together, pediatricians, intensivists, and these two support care teams, I'm sure, can take the right decisions. Pediatricians play a crucial role in early suspicion and referral. I'm sure around the world there are children dying as suspected sepsis who have underlying undiagnosed mutations. We should be aware of a variety of triggers. I showed you that umbrella of various triggers causing a common pathway of cytokine storm. So these triggers are critical to diagnose because sometimes the trigger itself will tell you what you need to do for your patient. Early initiation of therapy improves outcome, and HSCT, like I showed you in the few examples here, is a must for genetic HLH. If we leave them to go back into the community, they're going to have a repeat minor infection, which is going to trigger their immune system. And that second episode of HLH may be too late to get under control. Transplant is not a solo journey. Looking after HLH children is not a solo journey. So I thank all my colleagues in my department, particularly my colleagues, fellows, trainees, and the nursing team, without which we can't look after all these sick children. A shout out to also our intensive care team, our pediatric emergency team, who helped us immensely in getting a lot of these children into transplant. Thank you so much. Happy to take questions.
Thank you, Dr. Anand Prakash. That was a very tailor-made for pediatricians and very interesting journey of how an HLH can present to pediatricians. We are the frontline dealers with it, and we would be the ones first reference point. I do not see any questions, and there are lots of comments about how interesting your talk was. Whilst anybody having any question can unmute yourself and or you can put it in the chat box and I can air those questions to Dr. Anand Prakash. As we could see, you sensitized us to when we have to suspect HLH. Most of them seem to be a common presentation that would be our encounter. Any severe pediatric sepsis, any severe sepsis could be so. And you also showed about how it could be a mimic of other things and how we should not be jumping into a HLH diagnosis. And time is crucial here, as you also mentioned, and early referral or early intervention would be crucial in salvaging these patients. So tell us, give us a brief overview of how we would balance. We have a severe sepsis, a very high ferritin. How would we parallelly, as you said, things have to go tandem. So would we, at that juncture, what are the resources available for common pediatricians to make sure we are on the right direction, and how we balance the specific definitive interventions of all? It could be the trigger, it could be the HLH, and we will have to manage them all cumulatively. So please guide us as to how we would navigate this delicate situation. And I have another question, like we interchangeably use the MAS and HLH, the macrophage activation syndrome. And is it essential to delineate them, and how would we delineate them, and what are the different trajectories for both of them? So back to back, please.
Yeah.
Start answering us, and I will see if
Thanks,
I can fish out more questions.
Sure. Thanks, Dr. Vanita. I think that's the key critical question, right, which you and I deal with on a day-to-day basis. And I'd like to reassure everyone in the audience that there are no simple answers. Having said that, there are situations where when we get a consult, we, along with our colleagues in pediatric intensive care, have to follow the clinical course of the patient very, very closely. I don't think there is any magical one single blood test, or just by saying that, okay, I'm a pediatric hemo doctor, I feel this is HLH. Clearly, that's not the way forward, right? So I would list the following few points to try and delineate a sick child as having underlying HLH versus just a severe sepsis. The first is go back to history and try and sort out whether this child has had any previous episodes of severe infections. Has this child had any family history of consanguinity and sibling deaths? Has this child had episodes of sepsis which have required intensive care where the child has had cytopenias and then recovered? That already gives you a clue that perhaps this child's underlying immune system is not behaving normally. I'm not saying this child has primary HLH. I'm saying this child's immune system is not behaving normally. Could it be an underlying primary HLH? It could be. Could it be an underlying T cell immune dysregulation, CGD, all the primary immune deficiencies I showed you, XIAP, SCID? Could it be any of those? Yes, it could be one of those. So just by getting that clear history, we know whether this child has a odd immune system. When we have a child with a severe sepsis, let's say the child has no past history but has come to you with a very short history, just 24-48 hours, and comes to you in multi-organ dysfunction, right? The ferritin is more than 10,000. This is the child already has cytopenias. The child has deranged liver parameters. Child is in respiratory failure. This is the child who you haven't got all your labs back to say what is the underlying trigger. You haven't got all your serologies back. You've sent the blood cultures. You've started on broad spectrum antibiotics. But the fact that this child has deteriorated so rapidly may be a clue to you to say that the deterioration is not only because of the bacteria, it's because of cytokine release. Remember, I'm not calling it HLH. I'm calling it rapid cytokine release. So should I need to block the cytokines by the poor man's drug steroids or by the rich man's drug anakinra, right? And try and parallelly give therapy for sepsis, which is broad spectrum antibiotics, supportive care, inotropes, respiratory support, renal support, all of which every intensive care unit will do. But we do need to think, and I'm sure many intensive care doctors are rapidly, parallelly thinking, does this child have a cytokine storm? The third scenario is, remember that these children who have underlying malignancies like leukemias, lymphomas, none of these present overnight with HLH. Even the worst acute lymphoblastic leukemia will give us at least 1 week and will give us a peripheral smear with sometimes blasts. A child with a lymphoma will come with lymphadenopathy, hepatosplenomegaly, 2 to 3 weeks of fever, and come to you with an end result of cytokine storm. So in that situation, I'm sure when you refer to a hemonc colleague, they will say that yes, this child is having hemophagocytosis, but because of this relatively long history of 2 to 3 weeks, there may be an underlying disease which is triggering the HLH. This is not primary HLH. This is not dengue associated HLH. For infection associated HLH, all of us know in our own countries what is the usual pattern of disease. We know that in dengue, the first 3 or 4 days, child will have fever. After 3 or 4 days, the fever settles and the platelets comes down. And in the next 48 hours, child gets better. If the child does not follow this normal trajectory, fever continues, counts are supposed to improve, but after 5 to 7 days, counts are rock bottom. Child's liver and spleen size is increasing, not decreasing. LFT, which showed transaminitis in hundreds, has now gone to thousands. initial ferritin was, let's say, 2000, 2500 is now 8000, 10,000 within the last 4 5 days, then you know that this dengue, which is seropositive dengue, which may be PCR proven, is not following the normal trajectory of a dengue infection. And so, this is a child who's gone from 2500 ferritin to 8000, 10,000, whose cytopenias is getting worse. And so, the dengue probably has triggered HLH. So, I'm sorry, this was a long winded answer, but I listed out a few things at the bedside which helps us on a daily basis. Coming to your second point of cytokine, what is in the name, macrophage activation versus HLH. We now know that all of these are common final pathways. If you have an underlying systemic onset JIA, if you have an SLE child who is on treatment or presents for the first time with SLE, remember that JIA and SLE are inflammatory states. Usually they would have a high white cell count. JIA particularly would sometimes have a high platelet count. If you're thinking of SLE and JIA and they have low counts, then you would probably say that this child with SLE bar JIA has gone into macrophage activation. So for children who are known SLE JIA, if they come in with what looks like HLH, they probably have macrophage activation syndrome. The therapy varies because I'm aware that my rheumatology colleagues usually use methylprednisone. These are children who don't require etoposide. They do benefit from anakinra. They do benefit from high dose steroids, usually pulse methylpred. So working closely with there, and there are some children where we need to consult not only hematology but also rheumatology and get a consensus as to what we are dealing with while the workup, is going to come back. Thank you.
Thank you. Uh, some more clarity, but I'm sure it would be at the time of decision making. We would possibly have to consult the team before getting more certainty. During that window, would we have additional uh, markers, like how you said, some genetic markers? That would take a long time. The
Correct.
next generation sequencing would have its own turnaround time. So, is there any critical diagnostics which would assist us, apart from, of course, the acumen which you guided us
Yeah, so
in?
the
Is
usual,
there?
correct. So, like you rightly said, the next generation sequencing, even in the quickest of hands, would take at least about 2 to 3 weeks. We do have access now in our country to expedited exomes, and we have been lucky to, make some of these diagnoses relatively early. But yes, the usual turnaround time is about 4 to 6 weeks, and that's way too long for these sick children. So we often fall back on the constellation of ferritin, triglyceride, and fibrinogen with cytopenias. And I'd like to stress the point of looking at the trend of cytopenias, ferritin, triglyceride, fibrinogen. If you have access to soluble IL-2, you could do it because that's another marker. We didn't have it available for some time now. There is now a private lab which is doing it for us in Bangalore. But for those of you who don't, just looking at the trend of cytopenias with the usual criteria for HLH, looking at that trend would give us a clue that this is a child who is getting worse. So even with the first ferritin of, let's say, 2000 or 3000, you may not have opted to start on therapy. But in the next 48 to 72 hours, if these markers are going in the wrong direction, by that I mean ferritin is jumping to more than 10,000 or more than 5,000. If the fibrinogen, which was earlier more than 150, 200, is dropped to below 50 or 100, if the triglycerides have jumped to more than 150, 250, those are children you need to start on immunomodulation.
Alla Singapore.
Thank you, Doctor. Some more discussion points, if you can tell us about your institutional experience about bone marrow transplants. What are the common indications you encounter I know yours is a large center, but
Cooling oil
if you
mask.
can give us
I'll go
some
most of
guidance as to any optimal window of reference to bone marrow transplant, we wouldn't have any resources here for bone marrow transplant. We would
Correct.
always
So I think
refer
for the
to
correct. So for the general pediatric teams, I think besides HLH, which requires primary HLH, which requires urgent transplant, I would put a lot of money on aplastic anemia, because that is one disease which, if transplanted early, outcomes are very, very good. Ours is a university hospital. It's not a very expensive center. We've had very poor children coming in for transplant. Some of them are, just delivery boys working for online platforms. And these are children who, if come in early for transplant, before picking up infections, before having too many blood or platelet transfusions, outcomes of severe aplastic anemia transplants are very good. We heard in the first talk that you would always look for a matched sibling donor. If you don't get that, either a matched unrelated or a haplotransplant. We have quite a lot of experience with haplotransplants in severe aplastic anemia. And remember that if you don't give definitive treatment for aplastic anemia, these patients are going to die. So you should try and push for a definitive cure with a transplant. In the best of centers, 10 to 15% of patients are not going to get out of transplant. Transplant is a major treatment. All transplant centers counsel families. Dr. Sunil probably didn't have time to go over that. He talked about infections and GVHD. I'd like to stress that any child coming into transplant, family needs to know that their child may not come out of transplant. This is not meant to scare the family. This is not meant to discourage transplant. But I think it's critical for families to recognize that because it's a serious disease, HLH, aplastic anemia, transfusion dependent thalassemia, immune deficiencies, metabolic diseases, all of the diseases which need transplant don't have easy other treatments. So for the pediatricians, severe aplastic anemia, be it acquired aplastic anemia or inherited aplastic anemia, transplant is the only cure. Acquired aplastic anemia, immunosuppressive therapy can be used if the child comes in early, if there is no underlying mutation. So then immunosuppressive therapy is an option, right? But otherwise, severe aplastic anemia should be referred early for transplant, particularly if they have a matched sibling donor. The other group is, remember that leukemias like ALL, AML, only a proportion of them really need transplant. A proportion of them would do well with just standard chemotherapy.
I thought 12.
Right? So very important to stress that routine ALL and AML don't require transplant. About 50, I would say that about 50% of pediatric AML need transplant. So if your AML is of the intermediate or high risk group, if your AML has relapsed, then yes, definitely you need transplant. But I think, like Dr. Sunil rightly mentioned in his talk, our focus should not be only on malignant transplants. Our focus should be on these benign diseases in children like metabolic diseases, aplastic anemia, thalassemia, sickle cell anemia is important in some parts of our country. So that is also a group where, if the child is very symptomatic, should have an early transplant. Thank you.
Sorry.
Thank you, Doctor. Sorry for lots of interruptions. Our support is a little busy with the presidential elections, I understand. Uh, Sorry for those interruptions. Thank you very much for the really interesting and very necessary topic to discuss for pediatricians. Sensitized us for the awareness and how we diagnose and how delicately navigate the differentials and the cytokine storm kind of a picture that HLH poses to us. Thank you very much, and thanks, Dr. Sunil, as well. As I understand he's not logged in anymore. Thank you for taking up all the questions. I didn't have much audience input. I would relay to you in the form of email if I get any discussion questions,
Sure.
Doctor. Thank you
Sure.
very much.
Thank you so
It
much
was
for the
nice
opportunity.
meeting you, and it was really interesting evening for today. Thanks very much for the audience for standing by and for patient's presence despite some technical snags that we had. Thank you very much. Until we sign in after for the next topic, fourth Sunday of the next month. Goodbye, everybody.
Thank you. Good evening. Bye-bye.
Bye.
Thank you.